Good morning, everyone, and welcome to the Public Safety Solutions for Substance Use Disorder ECHO. My name is Julio Sorblanco, and I will be the facilitator for today's session. This ECHO is brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by Be Well, Texas, in collaboration with the UT Health San Antonio ECHO program. A few housekeeping items before we begin. We have live closed captioning available for today's session. If you would like to view closed captions for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions or having connection issues, please chat Echo IT Cato for assistance. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking, and we encourage joining by video and using the chat and/or raise your hand feature to post questions or share perspectives throughout the session. As a reminder, these sessions are being recorded and will be shared on our website. To ensure privacy, no personal health information is allowed at any point during the sessions. This includes client or patient names, addresses, birth dates, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask you to complete it as it provides feedback on how to refine these sessions to better address your priorities. We're approved for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credential. Finally, ECHO is an all-teach, all-learn environment, and we encourage everyone to participate in the conversation and raise questions. With that, I'd like to go ahead and move on to some team introductions. First up, we have Dr. David Miramontes. Oh, it looks like you're muted, Dr. Miramontes.
Hi, sorry. When you have that, it's being recorded, a pop-up comes on. You can't do anything until you say, okay. Hi, I'm Dr. Dave Miramontes. I'm the physician in charge of the San Antonio Fire Department, and I work at UT Health San Antonio.
Great to have you. We also have with us Dr. Brandon Del Pozo.
Hi, everybody. Coming to you live from the American Society of Criminology Conference in DC. My name is Brandon Del Pozo. I'm a professor of medicine and health policy at Brown University. Also a 19-year New York City police officer up through the ranks, and then a chief of police for 4 years in Burlington, Vermont. It's great to see everybody down in Texas.
Always great to have you. We also have Cynthia Mendiola.
Good morning, everyone. Again, my name is Cynthia Mendiola. I'm retired from the federal probation system. I was there for 27 years, working for the government. I'm also working in immigration safety, and I'm a trainer and coach in co-correctional interventions. Thank you for being here.
Thank you. Our case presenter for today is Shannon Churchwell.
Hi, my name is Shannon Churchwell. I'm with the San Antonio Fire Department. I am in the EMS division, 20 years in the department, 14 in EMS. I have a mental health background, as well as substance abuse background with the fire department. Thank you for having me.
Thank you for being here. And last but certainly not least, we have our didactic presenter for today is Joe Smarro. Joe, feel free to bring up your slides and take it away whenever you're ready.
Thank you, sir. Joe Smarro. I am CEO of SolutionPoint Plus and former San Antonio police officer. I was on the mental health unit for my last 11 years. And then the last year and a half or so before I left the department, I was doing a lot of officer wellness specific initiatives and hospitalizing our own cops that were struggling with suicidality or substance use issues. And so super excited to be here. The didactic I'm going to deliver today over the next 25 minutes or so is on burnout to balance. Again, I think something that we are all very familiar with in one way or another, but certainly relevant right now, especially as we enter the middle part of November, going into the end of the year, coming off a government shutdown, and going into the holidays. And so I think it's a timely topic for sure. Disclosure, important that this all be included, but there's no issues here that this is the standard language here that's provided from UT Health San Antonio. The learning objectives we'll go over again. There's a lot to cover in a short period of time, and then I want to get to where we can. I love the all teach, all learn approach, and so we'll jump right in. So what I'm going to move my box here. Okay. What burnout really is. Again, I think when we think of these words or terms, they've been tossed around, especially in a post-COVID era. We're all very familiar with them. We've heard them. But the one thing I want to outline quickly is that burnout is not a personal weakness. And I think that's it's kind of been a stigmatized term of that it's an individual problem, that if someone's feeling burnt out, then there must be an issue with them. I want us to reframe this as organizational misalignment. And the research that I'll be relying on top of a friend of mine who's a neuroscientist, Cami Sipp, but Christina Maslach and Michael Leiter, who do a lot of work on this. And what they talk about is how burnout stems from shifting priorities, unclear roles, lack of fairness, limited control, and chronic unpredictability. And as I mentioned, for decades, burnout was something framed as somebody that couldn't handle stress, but the research really tells us otherwise. And the work and the research shows that it comes from that systemic misalignment. It comes from environments where demands and expectations and resources do not match the human brain's design, which I think is important. And I don't want to get super heady, but I think it's important that we understand why it's happening. And it's especially true for public safety, first responders, because we work inside of these systems that often shift a lot faster than our brain's ability to recalibrate. And so that's not a personal flaw. It's just predictable outcome with chronic misalignment. It's something I did a lot in my own personal therapy journey. Still involved, but when I was on the department for sure. So 3 myths that keep us stuck when we talk about burnout. First one is that burnout affects people who can't handle stress. As I mentioned, not true. The truth is high performers are more at risk, and it's because of the nature of what we're doing. Myth 2 is time off will fix burnout. Just take time off. We know this not to be true. So taking time off is good. It can cool the engine, as they say, but it's not going to repair what overheated it. And this is to speak through like the, I guess, police or paramedic lens. I learned this as a cop was if I take someone to jail, it's not going to change their life. If I bring a person suffering from a mental health crisis to a hospital, it's not going to necessarily save their life. What's super important is on the back end of that discharge. And if they're returning right back to the same environments, it's likely to repeat. And it's the same thing for us on the first responder side is, yeah, taking a few days off of work is great, but you're going right back to the same environment with the same issues that you were struggling with before. And myth 3 is that burnout is an individual issue. Truth is, burnout is a workplace and system level issue. And I talk a lot about all systems having systemic issues because systems are created by people. And so when someone can't return to, or I'm sorry, when someone returns to the same unclear role, and I say that very loosely, like obviously we know what our roles are: safety, keeping everyone safe, protecting all the things, patients, whatever side you're on with this, correction, same thing. But within that, there's a lot of nuance. And whether it's heavy caseloads or short staffing or all of these issues that are really secondary, but front and center to a lot of our professions right now. And so the brain just kind of re-enters the same stress loop over and over and over. And so, again, I want to emphasize this point that it's not about being weak. So what's happening in the brain? The jammed gears effect. So when we stay in this like heightened state, the amygdala gets activated, which is not great because of what that's responsible for, right? And it puts us in this like fight or flight place for longer periods of time. Cortisol is elevated, which is the stress hormone, which again, I believe, and I'm happy to have Dr. Miramontes on here and other professionals, but when we see such low ages of death in our public safety professionals, my belief is that it's 20 and 30 years of just dumping cortisol and the impact that that has on us overall and our health. Our prefrontal cortex goes offline, logic, empathy, clarity decrease, and then motivation and collaboration all drop. And so the note here is that understand how the brain was evolved. It's strictly on efficiency and survival. So short, intense periods of stress, totally normal, but not chronic instability. And that's really what's kind of happened within the first responder profession for a very long time. And so as the amygdala is firing more and cortisol is rising, the part of our brain with prefrontal cortex that's responsible for logic and empathy and reasoning, decision making, it partially goes offline, which is why we also see a lot of behavioral issues within the profession. And I know we're talking about responding to community, but it's important for me that we understand when we're looking at human behavior, we're not looking at it through this like myopic lens of just this is a behavior and this is right or wrong. It's there's always a cause or a reason, a deeper meaning underneath what's driving that behavior. And so it's not that we're less motivated, it's that your brain is attempting to reallocate resources towards survival. And so it's really just biology, not failure. And so why do you feel it more as public safety professionals? As I mentioned, we work in systems that are under-resourced, emotionally heavy, bureaucratically rigid, unpredictable, constantly shifting, do more with less, take on more, do a couple full-time jobs, but just expect the same and do it well, get it right, try not to make mistakes. And so we're asked to show up in the hardest moments of people's lives, and especially specific to the substance use crisis that we all face in these communities, which is it's a very difficult thing to manage, to deal with, because there's a certain level of people have to want it at some point. And we know the data tells us of how many times it takes to bring someone into treatment before they're going to engage in treatment. And so oftentimes inside these systems, there's not a lot of clarity, predictability, or control. And then when we talk about the bureaucracy, inconsistent policies, shifting priorities, new chains of command, new direction, and this is from top down, middle out. And so first responders aren't burning out because the work is hard. We burn out because the structure around the work doesn't support the weight of it. And so that's the burnout signature for responders is I not only am feeling depleted, but also unseen, unsupported, which is not good. So what actually does help? If we look at these like system level truths, right? So clarify what matters. And the fewer priorities we have, the less cognitive overload we're going to have. Number two is create effort for recovery cycles. So if we can detect, I'll talk about the whole name it to tame it, but when we can detect and respond appropriately and recover from that. And then three is strengthening the connection and belonging. And so connection, we know, actually suppresses the threat response. It kind of, again, recalibrates us to realize that we're not in threat or danger when we're in connection. Belonging reduces burnout faster than these wellness perks. And I know a lot of agencies and departments are riddled with resources. Communities have a lot of resources. But again, it's the ability to access them, it's capacity, it's staffing. There's a lot of complex layers that go into all of this, which is why I think it's far greater than just a resource problem. And when our efforts are not clearly defined with like a start and an end, again, it doesn't allow the nervous system to truly reset. And in my experience, a lot of first responders kind of stay on duty, off duty. And this only just kind of permeates the issue and prolongs it, perpetuates to the next day, to the next shift, to the next week, to the next month, to the next year. And it goes on and on and on. And so these really are system level corrections. But they matter even when the system is slow to change. And so it's kind of two parts, right? Is what can I do selfishly, individually for myself? And then also like what can systems do? Because those two things are not always working in tandem, sadly. So some practical tools. When we look at clarity, right? So this is from Maslach's research, but the 6 burnout friction points. And I think just as like a task to give you all an assignment that are listening to this, I want you to really like listen, look through these and think over the next week, like, can you identify your top? Some people are going to be like, all those, and which is a sign in and of itself, right? But if we can really look at which one of these 6 is probably the most problematic in my life right now, whether that's workload, control, and again, that requires some awareness and insight, recognition, meaning wanting it, needing it, community, a sense of community, having your sphere of influence, the people around you, fairness, a huge problem, and then meaning. And burnout really thrives in ambiguity. And so this is why it's super important that we understand the first step truly is clarity, like just bringing awareness, which is why I like, again, insight and becoming self-aware is super important. And so these 6 factors are the core friction points that predict burnout. And when we can identify the one that is draining us the most this week, the brain suddenly will have like this pattern to work with. Because again, when we name it to tame it, as psychologists will talk about, but it's just about being able to name what's happening, bringing awareness to it, which will help us kind of get out of it. And even if nothing changes externally, right, within the community, within the resource community, within the agency, clarity will reduce the internal threat signal, which is important. Practical tools 2 and 3, connection and contrast. So when we look at the connection tool, right, to break the isolation spiral, again, another task or challenge for you, an invitation, if you will, is to reach out to a trusted person. I think, again, based on my experience of doing this for many years internally, there's a lot of people, because there's, peer support's a buzzword. There's a lot of these groups that exist, but if I don't know the individual, I'm probably not likely to reach out and share anything personal with them. So then what happens is we will talk to someone relatively close to us, but it might not be the best solution for us. Just because we trust them, know them, like them, doesn't mean that their ability to hold the information or provide any like reasonable feedback is going to be reciprocated there. And so it could actually make things worse. And so again, name what feels heavy. And it's not about fixing it, right? We're not trying to solve for, we're just trying to name it and to bring awareness to it. And then 3 is the contrast tool. And so this is about the micro recoveries and this idea that recovery is the presence of different. And so it's about doing something different than you're doing that caused the thing that's causing the thing, right? Hopefully that's not confusing, but really that's what, when we talk about recovery, it's just about doing something in the moment that is different than what we've been doing to get us to where we are. And so try things like a short walk, humor, laughter is great medicine, a tactile task. Again, I think environment is super important, like get outside in nature is super healing. Take a screen break for 20 minutes a day would be really incredible. It's I know some people are probably freaked out by that, but it really is important to get your face out of that false pursuit of dopamine. And then something deliberately unproductive. I think we're often too hard on ourselves about like, we have to stay busy. We have to stay busy. If we're not doing something, if we're not producing, then something's off. And one quote that I love for our professions is that the scariest place in the world for man to be is alone in their thoughts. And so because we don't like to be alone in our thoughts, we will overproduce. We'll work more, we'll do extra, we'll do all the things to avoid having to just sit and feel, because that is really unscary for a lot of us. And so when we think about burnout and how it isolates us, it really is, it's telling us that we're alone and that we need to push harder, but that's the trap. And as I mentioned, connection really does reset the nervous system. Even just like a 60-second conversation with someone, naming the weight of what's holding you down can be really beneficial, especially if it's with someone that knows how to hold space for that. And then in contrast, like real contrast though, it's what resets the mind. Not just rest, but something different, something that signals to your brain, this threat is not constant. I'm not physically in danger in this moment right now. And so these micro tools are just simple, but incredibly effective for our public safety communities. And when we look at the balance, so I want you to think of this as a signal, right? It's not failure. And clarity, connection, contrast is just a simple way to remember this. And then small wins, but consistently applied. Small wins consistently applied are going to change the pattern of behavior. And so I want you to think of burnout as just a sign that the way we're working is not working. That's all it is. And while I am a huge advocate of individual responsibility, personally, I live my life with the mantra that everything is my fault, because I've done a lot of work over the last 15 years on myself in professional settings from all different modalities. That for me, it's like when things are going really well in my life, it's because of the things I'm doing well in my life. If things are not going well in my life, it's because of things I'm not doing that I need to be doing for myself. There is no external power, external force, person, system that's ever going to get to dictate how I feel. because that's me giving away all my power. And so I know that, again, that takes a lot of work to get there, a high level of insight, high level of being emotionally aware to get to a place where you can take full responsibility for what's now. And again, I want to suspend that we all have common sense. I'm not saying anyone deserves to be victimized. If something personally bad happens to you, I'm not saying that is your fault at all. But everything after that of how we show up, how we feel, how we deal with it, how we treat ourselves is our individual responsibility. And while we are working to repair the bigger system, right, which is truly what I love about this whole Echo group, is that it's an effort to not just repair, but restore, to grow, to learn, to figure out better ways to make these systems more collaborative, to help us learn in community setting in safe spaces where, again, we do these didactics and then there's a case study and then there's discussion. I think it's really, really important to address these systemic issues. But in the meantime, we also have to look at what are we doing for ourselves, right? And so this is where the clarity, connection, and contrast and these really small visible wins will come in. And balance doesn't happen all at once. I think we have to be very careful about where we get our information and consume things. But this idea of just like waking up at 4:30 and throwing yourself in a cold plunge, that's going to change your life is it's a little bit ridiculous. And so again, I think every individual person, based on who they are, where they are, what's going on, how they got there, it's going to require the an individualized treatment plan. And so we have to be careful about like these mass generalizations of if you do XYZ, it'll change your life forever. Maybe for some, maybe for several, but certainly not for all. And so it's about just one stabilized moment at a time. And so while you are not responsible for the system that burns you out, you are responsible for protecting the part of you the system cannot rebuild. And I love this quote from John Kabat-Zinn, who says, "You cannot stop the waves, but you can learn to surf." And so everything that we talked about today with Burnout matters in the sense that we're not discussing personal failures. It's simply a signal. It's a sign that the way we're working is not working. Your organization does play a massive role in that. Systems, policies, staffing, leadership structure, all of this really impacts our mental load and our ability to show up at our best. But here's the part that matters just as much is we can't hand the entire responsibility off to the system. If we did that, we'd end up waiting for a level of change that might not ever come. And I'll be fully candid with you all here. I was experiencing this personally my last 18 months, the latter part of 18, but 19 and 20. I was really struggling. I knew I was unhappy. There was a lot of stuff happening outside of my control. I was giving away all of my power. I was frustrated within the agency. I had a lot of personal issues that I just couldn't seem to get out of. And through the help with my therapist, it was like, yeah, maybe you should leave. And I'm not advocating that everyone quit. Anytime I give a talk or I talk about wellness within the public safety profession, people are like, Joe, if you go around the country talking like this, we're just going to have everybody quitting their job. I don't think that's true, but I also think that there are handfuls of people in every organization that have either A, long overstayed their welcome, or B, have long overstayed their capacity to effectively deal with the day in and day out that's no longer serving them. And then they just stay stuck for a myriad of reasons, typically the most prevalent being they become prisoners to the pension. And so this is why personally I encourage everyone to become more selfish, not in a selfish, me, I'm the only thing that matters type of way, but truly in a selfless way and doing for ourselves first and foremost so that we can show up and do well for others. And I think that's super important. And if we don't prioritize ourselves, again, the job's never going to do it for you. And the truth is, the healthier we are, the safer and more effective our communities are, the people respond to, we're going to be able to handle these complex and dynamic situations much better when we are a healthier version of ourselves. And so remember the three anchors: clarity, connection, and contrast. The tools are not going to fix everything, but they will give you back the agency inside of a world that feels chaotic and unpredictable to help you stabilize yourself while the system attempts to catch up to you. And you deserve to feel whole. You deserve to feel supported. And you deserve to be someone in your own life, not just as a responder in everyone else's story. And here's the references. I don't know if the slides go out. Happy to share them, but that is my 20-ish minutes, I guess I did. I don't know where I'm at on time. I can't even see anything. But again, the main takeaway as I kind of flew through that is think of burnout as a system alignment issue, not as an individual flaw or weakness. Be selfish, take care of yourself. Clarity, connection, and contrast are the 3 C's to remember to help us get those micro, visible, small wins, which will eventually take root and change our environment over time. And with that, I yield back to the Echo Hub team for whatever is next. Thank you.
Thank you. What a great presentation, truly. I just have to say that first and foremost. With that, though, I would like to open it up to the Learning Network, our hub. Cynthia, I see you have your hand raised. Feel free.
Oh, yes. Yeah. Some of the things that Joe talked about, we experienced with probation officers in the mental health and substance use disorder unit where, I as a supervisor, I was seeing a lot of burnout and a lot of the topics that he was talking about, a lot of the officers wanted to fix, people's substance use disorders and mental health. And as I had to help them to understand that it's not about fixing, it's about understanding that your caseloads are high, prioritizing the people that really need help, and being ready with the resources and the tools that we had available for when they're ready to change. And so it was kind of like change a mindset because probation officers are usually action oriented people or action oriented. And so they just wanted to get things done, move on, change, and change for people. And you can't do that. And so it was just an understanding of that. So a lot of the things that he was talking about made a lot of sense in the field that I was in.
So, Joe, I was going to bring up so a lot of times with burnout, you have an officer, same person over and over again, same scenario. And it seems like the court system, the mental health system, EMS, the hospitals aren't, quote, fixing them. And that's really a drag on fire, EMS, police officers, corrections, even in the jail, right? They see the same person over and over and over again. And how do you suggest we reframe that experience in order to make it a more healthy interaction?
Yeah, one of the sayings that I have for that situation is that every opportunity is a new opportunity for a different outcome. And it is a reframe. But here's the real challenge is I get it. Like think about why we started this in the first place, whatever side it is, police, fire, EMS, corrections, dispatch, it truly doesn't matter the capacity. Nursing, when we get in these helpers and protector professions, we have this romanticized idea of what it's going to be like. I'm going to go out there and do this great work. But then to your point, the systems are like, well, wait a minute, like they're letting us down. So it seems because a hospital is like, look, we're not going to treat this person's acute mental health issue. If they, came out hot on a UA for amphetamine, they do the old treat and street, but we're never getting to the core issue. Take someone to jail, they get a bond out really quickly. The police officer is frustrated. The system doesn't work. But we have to recognize that like if every system was truly perfect, like if every system was exactly how each one of us individually wished it would be, how quickly then before we had a new complaint that the job was super boring. That like, oh man, I got this one call, I did this thing and everything was just perfect. I arrested this person and they spent their entire life in prison. I never saw them again. I took this person that was acutely suicidal to a hospital. They got treatment, they had transportation, they took their medication, they never needed help again. We would very quickly run out of people to help. And then we would be frustrated that the job is super boring and there's no one to serve. And so I think it's truly just reframing it to gratitude. Like, thank God I live in a community that has this level of problem so that I get to stay busy and do the thing that I was actually willing and called to do. And it really is a purposeful reframe to gratitude instead of frustration and accepting that, yes, I've dealt with this person. Yes, it's a familiar face. Yes, I've had this same house 15 times in the last month, but maybe this is the time. And if it's not, maybe it's next time. And if it's not, maybe it's next time. But like, what else are you going to do otherwise? And so it's really just holding on to that perspective rooted in reality instead of fantasy.
Andrea, so you have your hand raised. Feel free.
Oh, yes, no, I just wanted to say that I believe personally that part of the reason why we all feel so burnout is not just because of professional responsibilities and work and all the things, but I think also the excess exposure to information, even unwillingly, like you don't want to, but when you open your phone, you are exposed to all these horrific things that are happening around the world. And somehow, consciously or unconsciously, we tend to carry that with us because we cannot do anything about all those lives that are being lost and all those horrible tragedies that are happening, or all those unfair things that we hear that are taking place somewhere remote, in a remote place in the world. So I think that burnout has a lot to do, I personally think, with the way we're processing the excessive load of information that we get from phones and notifications and all that. That's all that what I just wanted to say.
Yeah, I say audit your algorithms because I tell people if you hand me your phone and I go to your Instagram or TikTok or Facebook and I scroll your feed for 1 or 2 minutes, it's going to tell me a lot about you because those are set up to give you more of what you spend more time on. And so it's really important that because we know that we're going to continue to throw our phones in our face, that you're very mindful about what you are consuming because I think we do become what we consume over and over and over. But it's also part confirmation bias, right? A lot of us, we're seeking out some way to validate our own opinions. And so if I have a belief or an idea, I want to search out that which is going to validate that, which is only going to make me feel right, which is what we want to feel safe ultimately. And so, yeah, we consume these in like very high amounts to feel righteous, to feel like, yes, my point is valid, or yeah, the world is scary. Yes, people are dangerous. But again, I think we have to have a balance with that too. And it's a great point you bring up, Andrea, because it is just, I tell public safety, regardless of which vertical, but like we are saturated in human suffering. And so it's important that we balance that out when we're not in it because of a requirement that we need to be in it on a professional level, that when we're outside of it, we're truly outside of it as much as possible and not, looking at the YouTube videos and the TikToks of all of the horrific things happening around the country because it's easy to find. But it's also easy to find a lot of beauty and peace and kindness and wholeness if you look for it.
I think those are all really, really great points. I'd like to give a final call for any questions for Joe on his presentation. Any final thoughts anyone would like to share, perspectives, insights? All right. Well, absolutely no worries at all. Again, thank you so much, Joe, for this presentation. It was great. It was I was very much left speechless. Um, as I'm sure the rest of our learning network was as well. Cato, with that, I'd like to go ahead and move on to our announcements. Thank you so much. To claim your CEU credit, you must complete the post-session survey in the chat or by the email sent after this session. Complete the post-session survey and select yes on the question, are you applying for CEU credit for today's Echo session? Your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you have any questions, email bewelltexas@utesca.edu. And when you complete our post-session survey, you help shape these sessions around your needs. We created this series for you, and your feedback truly matters. Your ideas, experiences, and suggestions guide how we plan our future sessions, what topics we cover, how we deliver content, and the kind of support that we offer. Please take a moment to complete the post-session survey. We're listening, and your input helps us make this Echo series even better. Next slide, please. Do you have a difficult case that you or your team have encountered? CSAT offers the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and fellow providers who understand the real-world challenges that you face. There is no need to prepare a formal presentation. We will provide a case form to fill out to assist with your case presentation. By sharing your case, you'll gain expert clinical guidance, supportive peer learning, and evidence-based resources tailored to your case. To submit your case, please email us at csat@utesca.edu. Next slide, please. And a call for presenters for TXSUS 2026 is now open. We invite professionals across substance use and behavioral health, including researchers, providers, peer specialists, and community leaders, to submit presentation and poster proposals. Share your innovative solutions, emerging research, and collaborative approaches that advance substance use care and recovery in Texas. Submit your proposals today at the link in the chat. Next slide, please. And lastly, please join us for our next Public Safety Solutions for Substance Use Disorder Echo on Thursday, December 11th at 11 a.m. Central Time. We'll have Brandon Del Pozo presenting on the careful implementation of behavioral health interventions in public safety setting using implementation science in the last session of the year of 2025. Thank you so much. Let's go ahead and move on to our case presentation for today. Cato, if you can bring up the case form. Shannon, please walk us through the case.
All right. Good morning, almost afternoon to everyone. There's these cases that kind of sit with you. You wonder how they are doing afterwards. Especially in EMS, we don't have the opportunity to follow up with people. Thankfully, we have a mobile integrated health program that actually is multifaceted. It is one of the legs is a core team, which is a mental health team comprised of, a firefighter who's a paramedic, a clinician with a Center for Healthcare Services, and also a mental health police officer. So those calls are screened and by the officer. And this is a case that happened on the 23rd of October. The mental health team noticed that this was a need for, our actual core team and not just a patrol officer. A lot of the times the patrol officer will actually call us out. So it's imperative that the officers that are working on the core team actually find these cases as they're screening all of the calls. And as it came in, we noticed that this is something that we could respond to. So we did. A 49-year-old female was actually at a drug and alcohol treatment facility. The staff called stating she was expressing suicidal ideations and that they needed help, that her son had died and that she was saying that she wanted to hurt herself. When we arrived, we assessed her. We spoke with her at great lengths and found her to not actually fit the criteria for an emergency detention. She was saying in group during one of the sessions there at the facility that she could to see her son and be with her son again. She could see herself doing something, hurting herself to get there. She said that she didn't have a plan to do that. However, the facility said that's a huge red flag for them. And according to their, rules and regulations there, if somebody says that, they have to escalate it. So we were there. They escalated to us. We have 3 different levels of people that can help her, from the medical aspect, from the legal aspect. We have social work with the clinician. Fortunately, I was paired up with an officer that is a PIC officer that helps mental health as well. And I used to be on that team. So we work really well together. And the clinician that normally would be there wasn't. It was the follow-up clinician, the person who would actually be contacting her 24 hours after we've made contact with her. The issue that we had was after we had spoken to her, we realized that her grief regarding her son's death, her son had died of Huntington's disease. So it's not like it was unexpected, but I've never lost a child. And I can't imagine the grief going through that. And she's never, ever been seen for that regarding counseling or help. So she turned to substance abuse. She was homeless. She said she lived in a lot of ditches. She was doing a lot of methamphetamines and drinking alcohol. She's lost pretty much everybody in her family. Her parents have died. Her son had just died a year before. So she's really struggling. The facility that she was in to give a little more context, she's has lack of sleep. We were talking about lack of sleep and cortisol levels just now with Joe. Her roommate has sleep apnea, so she's not getting any sleep. So she was just kind of at her wit's end this morning and she was feeling frustrated. But speaking out of frustration, the facility itself said we can't allow her to stay. She didn't meet ED criteria for us. However, the facilities rules an hour and a half into this call finally said we can't allow her to stay. So we spoke to her about maybe seeing someone at a mental health facility voluntarily and explained to her it is by no means a step back um, in your recovery for your substance abuse. And unfortunately, as soon as that happened, the facility says, oh, well, if she's not back in 24 hours, she'll have to restart the program. She had been 10 days sober, and that's the first time she had been sober that long in approximately a year. She was very proud of herself. Um, Personally, we ask why you haven't followed through, like what's stopping you from doing this, because we need to find that connection and find a way to kind of bridge how can we help you, what type of support services you need, and what's keeping you here and not committing suicide or, going back to drug use. And she said it was for her. She told us, and that's the first time that I've been doing mental health for the last 5 years. That is the first time that I've ever heard someone say, I'm here to finish it out. I'm here to finish out the substance abuse treatment center. I'm here to see myself through it, and I need to do that for myself. And that's why this case stuck to me, because a lot of people say, I have to do it for my children. I have to do it for this and do it for that. But just as Joe was saying in his presentation, you have to be a little selfish. You have to do it for yourself first. And that's exactly what I told her and teach to a lot of firefighters. And when they're talking around the table about having trouble, I say you can't pour from an empty cup. And in the fire department, you can't set yourself on fire to help anybody else. So I told her the same thing. So she voluntarily went to treatment facility. She was not released within 24 hours, but we advocated that she not have to start the program over. And we fought really hard for her to do that. It was stressful. Obviously, almost a month later or 3 weeks later, I'm still, you know, actually helping her. She's still in the program as of now. She's doing really well. The issue that she and we thought that if she wasn't able to get back into the facility and she had to start all over, we felt that it would catapult her back into drug abuse and living on the streets, and that's something we just didn't want to do. So we put it upon ourselves to really fight for this perfect stranger because she wants to do it for herself. And even the ones that don't want to do it for themselves, we fight and we advocate for them. She is currently in the program. Her program was supposed to end and she was supposed to graduate November 10th. She volunteered and discussed it with the team to stay longer. Her actual discharge date now should be November 23rd. And as of November 23rd, she'll be going to sober living. I did find that the grief counseling is something that she really needed, and she wasn't going to be able to wait. She felt so frustrated. She felt like the group therapy at the treatment facility was helpful for the treatment aspect, but her grief and kind of her reasoning and how she fell into drug and alcohol abuse was not being, those needs weren't being met regarding the counseling. She needed more one-on-one, and the facility does not provide it. I offered to try and find her, we as a team offered to try and find her some separate counseling that could come in specifically for griefs, as the facility didn't provide it. And they said, no, that was a conflict with insurance. So a loop around, I asked her if she was faith-based and if she had a church that she belonged to. And she says she hasn't been in a long time, but she would like to. So we actually found her a church that has specific grief counseling and support services for drug and alcohol abuse, like sobriety support. And they're going to be meeting her with her this week. So, as many obstacles as we had with this case, I'm pretty proud of the team for coming together, sticking to it, and following through with her. Something that we wouldn't have been able to do 15 years ago or 14 years ago when I got into EMS. You would just wonder how somebody's doing. And now we're actually able to, with all of these entities comprised with the core team, we're able to follow through. My questions regarding how she can get support at the very top, that's the first thing I thought of. When she goes to sober living, how is she going to maintain support through the programs that she's in now? Yes, I understand that we've connected her with church services, and that's something that she wanted that was faith-based. But how is she going to, what continues on in sober living? Is that all based on insurance? Is that based on what program she's enrolled in, whether it's Be Well or CHCS or things like that? How can we advocate more for her after she's been discharged? That's it for me.
Great. Thank you so much for that case, Shannon. With that, I would like to open up the discussion to the floor in our learning network. Are there any questions or comments from our team or learning network for Shannon?
It's such an interest. This is Brandon. Thanks for that presentation. It's such an interesting case because what spurred all of this was the belief about suicidal ideation, and then it led to like a cascade of like not intervention, but like trying to figure out what she needed and where to put her. And like, so I'm of two minds. I just wonder if you can explain this. Like, there's always this idea of like no wrong door, meaning like whether you come into contact with the police or you come in contact with the emergency department, you get linked to the services you need. But yet at the same time, this was something that like people maybe misinterpreted or took a reporting mandate and then spooled it up into a crisis. Like, I guess what I'm trying to say, what if she'd said this to anyone else and it wasn't a mandatory reporting situation? Like, what would have changed and what would have been different? Or would that be a missed opportunity? You follow what I'm saying? I can try to rephrase it, but
No, I understand because any one of us have been in a situation where we have said something similar. I'm on my 18th run in an EMS unit. I'm exhausted. I'm tired. I haven't eaten. If we make another run, I'm just going to open the door on the highway and just be here on the highway. Nobody's doing this, but it's a state of frustration. And you're just like, I just want to eat dinner. And I feel like because it was in that group setting, I thought it was unfair of them to escalate it the way they did instead of speaking to her. However, they are only substance abuse and alcohol abuse counselors. They're not grief counselors. They don't have and they said this specifically, we don't have the capacity to help her in that way. And where our hands are tied. So the frustration was that she fought for herself and said, no, 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 I didn't. I'm not saying I was going to do it. I'm saying I miss my son so much that I could do this to be with him. And we felt like the escalation um, led to something it shouldn't have been. But then I also feel that if that hadn't have happened, we wouldn't be following up with her. We wouldn't be helping her any further. She wouldn't have the services that she really needs because if she leaves sober living, if she goes to sober living and she's not dealing with those things,
right.
It
she's
it
got to
almost it
right back.
almost sounds, this is me, Cynthia Mendiola, but it almost sounds like maybe there wasn't a staff member beyond, in other words, you said they're like counselors, substance use disorder counselors, so that's the scope of their work. They were felt that they would have gone beyond their scope of their licenses. And so
Correct.
it seems to me like maybe there wasn't maybe another credentialed individual that could have taken that over and said, okay, I can deal with the suicidal ideations. Is what I'm.
I believe that is spot on when it comes to her. She's never attempted. She's completely frustrated. She's been put into a situation where she's trying to get help. She's not getting sleep. She's not able to take care of those needs. And then compounded with, oh, by the way, we're asking you to leave and be evaluated by a mental health facility. However, if it's longer than 24 hours, which is out of her control, you have to start all over again. And that was frustrating for her, even though we transported her with the core team to the mental health facility. And from the mental health facility, the team from the treatment center picked her up. That she's not leaving to go on some crazy bender. She's in our control and in our sights the whole time. And thankfully they said, okay, we'll waive that. I do believe that treatment centers should have somebody or they can bring someone in that specifically deals with that, because I can see that being an issue with more than one person. And they don't have
When you
any
say
one-on-one group help. I mean, it's all
when you
group help.
say when you say deals with that, what do you mean? Just to be more
As
specific.
in like grief specialist or somebody that assists with one-on-one counseling. The facility only does group counseling. So she said that it's very difficult to get a word in when you have 15 people in the room and you're listening to everyone's drug stories and their abuse and how they've been led to this point in their life. And it's difficult for her she says, all the stories are very sad and I feel for them. She said, but I'm not really getting much out of it, is what she said. I feel like I need more one-on-one help.
And I think that just that kind of adds to what Joe was talking about as far as the systemic, the systems and how the systems are working, because there's some that are lacking certain things and there's nothing that you can do. It gets frustrating, but the great thing about this whole situation is that your team is there, because your team was able to pick up those pieces that were missing for this one person and saved a life, I think.
I think so too. I think so. In fact, she doesn't know this, but I'm scheduled to visit her today to because I thought she was going to be discharged. And so I followed up a couple of days ago and she's there. And I just want her to know that, we're still in her corner. We're still trying to help her. But I thought this was serendipitous when with this came up, and then I chose to use her as the case because I really would like to know how to navigate going to sober living and still providing her with support services. And I'm sure her case manager is handling a majority of that. But as everyone knows, a case manager has not just one person. They're usually overloaded with a lot of patients, a lot of clients that they have to deal with. And then most of those people are burnt out too because they're faced with the same things.
How
Yes,
much of this
definitely.
do you think comes from lack of coordination between it seems like you have this mandatory reporting process or even out of genuine concern, but then it spurs this set of responses that aren't tailored to deal with the situation of somebody in this type of recovery situation.
Specifically, you kind of hit the nail on the head. I wasn't going to mention it, but the director of the facility contacted the CEO and said, "Okay, well, here's the deal. She said this in this group session, and now she's saying I didn't mean it. I said I could." And without the CEO knowing what she said, what absolutely happened, she said, "No, we have policy. No, we have policy." So I think that there's an issue with communication, especially between teams. They brought us in as a team to get our opinion on the situation. Excuse me, they called it escalating it to a specialty team, which was us, and then completely disregarded our our findings. And so that was frustrating for us.
Thank you.
Andrea, I see you were unmuted. Did you have a question or some insight
Oh
you
no,
wanted
I
to
just
share?
want to say that I find it interesting that in that facility where she was out there so rigid and strict in terms of, telling her if you leave here more than 24 hours, you have to start all over again when the person is going to another mental health facility. So I don't understand what is the reasoning, the rationale behind that rule, really, because it seems to me that it's going to put her back to where she was before.
Yes, and that's exactly what we said. I understand the facility because it's a drug and alcohol treatment center says if you're gone for longer than 24 hours, you have to restart over because this is just most likely based on their experience. If somebody's leaving, they might be going to a party or going to do drugs or going to drink alcohol and then they come back. So the the fact that they didn't have a separate clause or we had to really fight for over an hour with them about bringing her back and not repeating from beginning because she's going to a facility, like you said. There's no reason why they shouldn't be able to say, okay, no problem. Because she's being discharged. I mean, she's temporarily leaving here and going to a facility where she's getting treatment for her issue. The issue that you won't allow her to stay for, now she's doing what you're asking her, but then you have to start back over. And I don't know if that's just an internal policy of theirs and they just didn't understand, but I'm glad that we were able to fight for that. But if she was leaving voluntary and we were not involved and she says I'm having trouble, I'm going to go to a mental health facility, she wouldn't have anybody to advocate for her.
And I do see that we have a question in the chat. So Megan, would you like to unmute and ask your question?
Just wondering if any schedule for 12-step meetings was provided for her to get plugged into that community.
I don't know that she has. At the time of our meeting on October 23rd, I asked her if she knew what that was. She had no idea. I talked to her about Club 12 because I'm quite familiar with them and have been referred a lot of people to them over the years, but she said that she hadn't. I think that they establish and they start that in the actual treatment facility, and then when upon your discharge, I think that's probably or latter part of the program is where they probably introduce that. And I'm saying probably because I'm really hoping that's the case.
Thank you for that. Andrea, I know that you did ask a question, which is, and this is directed towards our group, of course. How can we advise on how to navigate sober living or transition to a new space? Any thoughts from our group, from our learning network, or Shannon, if you have any ideas?
I'll start off with that was a kind of a question of my own, as in this is the furthest I've gone following a case because now I'm on the team where I have a case manager and we have a police officer and a paramedic. So I handle the medical aspect and the officer handles, we both handle the ED aspect of it and the clinician's there for all of the social needs. So I don't know that that is addressed as early as now. She has a discharge date of November 24th. I don't know how long that takes to find sober living. I have no idea what happens when she gets to sober living and how much support she's going to get from that.
Any final questions that we have for Shannon? Any final thoughts of advice, comments, anything from our learning network whatsoever?
From my understanding, meeting people at the Substance Use Disorder Conference this last September, Cicada has a lot of programs where they have peer support or recovery support individuals to help those that are in recovery through some of the processes that you're talking about. And they're really connected with those resources that are out there to help them navigate through the different resources.
I've worked with Cicada with our mobile integrated health program, and that's wonderful. I know who they are and how well they do. I just didn't know that they did follow up, when it comes to like sober living. So that's good to know. Thank you for that.
Great. Thank you all so much, and thank you all for this conversation. In the interest of time, let's go ahead and move on to our case summary. Brandon, could you give us a summary of recommendations for today, please?
Yeah, double in the interest of time. I think this was a great conversation, and I think it posed some challenges that we can briefly go through. It seems like we can sum this up by saying there was a person who had a set of complex needs, and as she tried to navigate them, even in standing up for herself, like the two systems that she became involved in didn't exactly sync up in the most productive way. In the first time, in the first aspect, she needed to, when she expressed an emotional, sentiment about possible suicide, which was something that we all commonly do. It triggered a reporting requirement that then brought on resources that, if she were to truly undertake them, would put her in danger of noncompliance with her treatment regimen at her residential place. But also, it shows that the residential location she was at didn't have the right treatment resources for her that would have helped deal with that, meaning she would have benefited from one-on-one treatment rather than group counseling because of just the complexity of what she was dealing with and the inadequacies of group counseling. Sometimes it's perfectly what people need, sometimes it's just not enough, or sometimes it's not the right setting. So one of the recommendations is to, number one, comply with procedures, but use a common sense approach about what levels of intervention are necessary when people say certain things. And I know people are very wary about, not reporting something they should, but we have to think about the consequences of that. Number two, understand that there's complex needs that go beyond simple group counseling. So if you're providing the service out of compliance with a procedure or a grant or to check the box, or you're designing this type of program and seeking funding for it, it would be helpful to make sure that there's the availability of some more intensive one-on-one counseling for people with needs like this. Then also coordinate in advance with outside institutions and agencies so that somebody doesn't, like, in a very technical way, default on some requirement. Like, you can't be gone for that's because you escape out the side window and go relapse with your friends. It's not because you're removed from the setting to get an in-depth screening because you couldn't get what you needed in the setting, right? So a lot of careful coordination to, like, overcome the bureaucracy and stick to, like, the right standards of care and the best, like, treatment for the patient will be helpful, like, in a collaborative sense. That could have avoided a lot of the heartache of this case. And I see Shannon nodding, so I'm glad it seems to be I'm glad it's resonating. So thank you.
Yes, absolutely. Thank you.
Great. And thank you all for joining today's Echo session. As a reminder, to earn continuing education credit, please complete a post-session survey using the link in the chat. If you would like to present a case, please email the Be Well Texas team at bewelltexas@utesca.edu. We look forward to seeing you at our next session, Thursday, December the 11th at 11 a.m. Central. Have a great rest of your day.